Prior to the dawn of democracy, there were very few opportunities for people living in townships to access quality, private healthcare at affordable rates.
It was difficult then to get into private practice because most private hospitals only admitted white patients.
You know, those days are apartheid days. Patients were allowed in the private hospital, but I was not allowed to go and see the patients there. At one stage, I was the only black specialist in this country in private practice. I was a pioneer going to white hospitals. I could see the reverse. That black doctor is here again.
Skilled black medical staff were employed at government and private hospitals far away from where they lived. And the community who required private healthcare services had to travel long distances to hospitals located in formerly white areas, often at considerable expense. In the late 1960s, a group of visionary businessmen, including Dr. Chileshe Mpehle and Mr. Richard Maponya, under the leadership of Dr. N. Motlana, formed a company whose purpose was to establish a medical scheme and private clinic to serve the disadvantaged communities. In 1985, the group opened its first private hospital, Lesedi Clinic, now renamed Dr. S.K. Matseke Memorial Hospital, finally realizing their vision of bringing private quality healthcare to township areas. That led to the formation of the Clinics Health Group in 1992. It was the futuristic ambition of Dr. Peter Matseke that saw the current and continuing growth of Clinics Health Group to greater heights. Clinics also facilitated the advancement of previously disadvantaged doctors by enabling them to open their own specialist practices in these underserviced communities. 30 years later, Clinics continues the legacy by being a respected healthcare group consisting of 6 private, state-of-the-art hospitals located in Soweto, Johannesburg, Vosloorus, Vereeniging, and Mafikeng. Together, these hospitals have over 1,500 beds and 23 operating theatres. Facilities include ICU beds, 24-hour emergency units, renal dialysis, mental wellness services, and 24-hour urgent care. Clinics continues to attract top healthcare professionals, which enables us to meet our mandate of providing a high standard of healthcare products and services, quality patient care, and friendly service. Clinics is committed to providing economic opportunities by ensuring that procurement is outsourced to local businesses, supporting entrepreneurs and ensuring a bright future for all. We continue to be administered by a team of diverse and highly skilled medical practitioners who, being rooted in the community, know just what you need to thrive. Clinics Health Group. You are family.
Good evening, colleagues. It's a great pleasure to be with you once more this evening. Welcome to our Clinics Health Group weekly webinars. And it's exciting this evening that we've got a presentation on one of the latest modalities of managing patient care in our facilities or the hospitals within the country and just across the roadway from where we are. We may be slightly delayed this evening. Our speaker has been battling to connect. And so we'll just check and Zuki will tell me once Dr. Chileshe Mpehle is connected. He was telling me a few minutes ago that it was allowing him to log in. And Dr. Mpehle, if you are...
I'm connected.
Oh, you are in. Thank you very much, colleagues. It's exciting times again once more this evening as we try our best to bring you current information on what's happening within the medical field. And as clinics, we're excited to be engaging with you and to be partnering with all of you who've been coming in and supporting this program. You're not just only supporting us, I think we're doing it for the patient because we need to be abreast with all technological advances and current trends in patient care. So this evening, we also want you to join us, and we are also requesting that as you log in, make sure that you submit or provide us with all the information about yourself, so that at this we can forward your details to the relevant regulator. And one of the things, Dr. Mloy, is to say when you log in, please make sure that you mute yourself as you enter. I think this is what we are expecting of all colleagues as they join us. Just mute yourself and make sure that you switch off your video also, so that at least we have minimal interferences during the presentations, and so that we give the speaker the due respect he or she deserves during the presentations. And so this evening we continue with our programs. We have an exciting lineup for just one person, exactly, a young person, and don't be surprised about the first name. He's from the Eastern Cape, Dr. Chileshe Mpehle, who's a specialist obstetrician and gynecologist, got his fellowship from the College of Obstetricians and Gynecologists from the College of Medicine, South Africa, and also his junior degree from West University and BPCH, and is also as a BSc from VETS also. Dr. Chileshe Mpehle is currently a gynecologist at Chris Anipara Hospital. He's an astute clinician, an aspiring academic. I don't know why we're using aspire, but he's already there. But he's known to his friends, family, and colleagues alike as Chills. So we'll chill together with him this evening. Dr. Mpehle completed, as I mentioned, his bachelor's degree at VETS in 2011, and is also an MED supervisor at the same university on obstetrics and gynecology. And he's also done a project titled Burnout in Registrars during the COVID-19 pandemic, the University of the Witwatersrand, and also the gynecology circuit. Aside from his medical career, which is something exciting, is that he is an aspiring entrepreneur. Since his teenage years, during this years as a tutor, he developed a time management system called Pyramid. He currently runs this program during his spare time, assisting university students, high school students, and young professionals with the management of time and target achievement. So it's a great pleasure to welcome you this evening, Dr. Mpehle, to address colleagues from various disciplines and also from the public and the private sector on the topic of HIFU. You said you'd explain it to me. Let me go into that, the future of fibroid treatment in South Africa. Thank you, Doc. You may share your screen.
Thank you so much, Dr. Bila, for such a nice introduction. I'm going to try and share my screen. If you can just confirm when my PowerPoint is sharing.
Not yet. Yeah, it's coming. Yeah, sure. No, it is sharing. Yeah, sure.
Right. So to make sure.
Yeah, if you go to Zuki, will help you to go to power slide presentation. Sure, great. Yeah, all.
Is it sharing?
Yes, it is sharing.
Thank you. Sharing, Dr. Bila.
Yes,
okay.
It is.
All right. Once again, I would like to just say thank you very much and good evening to everybody who is attending this talk this evening. I've already been introduced, so I won't go into that again. We're running slightly behind on time. I'll try to be succinct in what I present. There is a lot to talk about the topic. But before I begin, I would just like to give an acknowledgement to number one, clinics first and foremost. I think this is a great initiative that you guys are running. I would also like to thank Professor Adam for giving me the opportunity to come and present this evening. I'd like to also mention Dr. Raymond Stetson, who without him, I would never have even been doing HIFU. I would never have learned the procedure. And I'd like to thank Melissa Williams, Dr. Melissa Williams as well, who's one of my colleagues in HIFU who assisted me with putting together this presentation. Now, before I begin, everybody, the screen that the picture image I'm sharing on the screen today, I know you probably asked yourselves while you look at it, what are you looking at? Now, for those of you that do take time to attend the movies every now and again, what we are looking at is the fictional city of Wakanda. Now, this is a city that was featured in one of the highest grossing movies of all time, you know, the Avengers series. And the reason I'm placing this city here is because it is a fictional African city that basically is famed for its technological advancements. Now, while I'm presenting a topic today that is not an African-made technological advancement, I wanted to reiterate the point that the only way we as a country and we as a continent can advance is to, number one, stay up to date with technological advancements. And number two, once we are up to date with technological advancements, seek to further our own understanding in technology and seek to bring our own advancements to the future of healthcare and just technology in general. All right, so HIFU, a quick list of what I'm going to be talking about. I've split my talk into four sections. Number one, I'll give you a bit of an intro, a bit of a history about HIFU. Number two, I will then, in part two, I'll talk about, you know, the actual HIFU process, fibroid treatment, and what we've been doing at Baragwanath Hospital. Part three will then be about some of the outcomes that we've had over the years in the department, the research and a few controversies that I'll highlight. And then part four will open for a Q&A. All right, so to begin, what is HIFU? Now, this is a question I've been asked multiple times by many people that are doctors, some are not, some are laymen. But I realized that in the past 2 years where I've been in the HIFU department, not a lot of people actually know what this HIFU thing is. And as I told Dr. Bila, I will explain all now. So it stands for high intensity focused ultrasound. And in brackets, I've placed ablation of fibroids because that's actually literally what we are doing. We are ablating or burning the fibroids using ultrasound technology. Now, contrary to what people might believe, we think it's late technology. However, HIFU actually dates back to the 1940s, where they first postulated that if we could focus ultrasound waves, that theoretically we could generate heat and therefore ablate tissues. In the 1950s, they started looking at using ultrasound to burn liver, and this was in Chicago in the United States. Then in around 1980, in the 80s, late 80s, early 90s, the very first HIFU treatment happened. And this was a case where we had an 18-year-old with osteosarcoma. Now, that is a bone tumor, a malignant bone tumor that was treated primarily with chemotherapy. However, after the chemotherapy, they did some scans to see if there was still radio uptake in the osteosarcoma, and the radio uptake was still positive. They then used HIFU to actually ablate, and post using HIFU on this osteosarcoma lesion, there was complete resolution in this 18-year-old. Then the notion of the biological focal zone came, which is technically the area in which, if you focus ultrasound waves into one area of tissue, there will be a change, a denaturation of that tissue on that focal point. And that was called the biological focal zone. When we look at HIFU, ultrasound, we have two types. We have number one, MRI guided, and number two, sonar image guided versions. Now, what I mean by this is we have to first see what we're treating. And there are two ways to see or image what we are treating. And that is number one, by doing an MRI, which has classically been used. And recently, we now have sonar guided HIFU, which allows us to actually visualize what we're treating in real time. And this is the new and the current development and the system that we are using at Baragwanath Hospital. All right, so what are the applications for such a technology? So it has been used to treat benign and malignant solid tumors, but specifically for gynecology, in our gynecological sense, we use it for treating uterine fibroids, but we also can treat adenomyosis. The urologists do treat prostate cancer overseas. In fact, there's quite a large series of prostate cancer treatments, liver cancer treatments, breast cancer has been treated as well, and it is used for palliation in the setting of pancreatic cancer patients. I've already highlighted bone cancer and I've explained how it is effective in the treatment of osteosarcomas. And they are now looking into the application for treating renal cancers. So just touch on the physiology and how it all works. I'm sure most of us, when we were young, had a chance, or hopefully had a chance, to one day play with a magnifying glass in science class. And what we found was, if you do focus the sun's rays using a magnifying glass, you can focus it on a specific point. At that specific point, there is a large amount of heat generated. Most people use it to burn papers, some burn leaves, some children chased ants. But it's a commonly known thing that if you focus lights, the sun's rays using a magnifying glass, whatever is between the magnifying glass and the focal point will not burn. However, what is on the actual focal point will burn because there's a large amount of heat generated. This is completely analogous to what we are dealing with when it comes to HIFU. Now with HIFU, the only difference is we're not using the sun's rays, we are actually using ultrasound technology. Now the image on the right that you see, that is a depiction of our HIFU system where we have a transducer. I just want to get a pointer here. Okay, so we've got a transducer which emits the sound waves, and it emits them from a concave piezoelectric plate that then sends the sound waves towards our focal point. And at the focal point of convergence, that is exactly where we have treatment and denaturation of the tissues. Now, this liver-shaped organ, we can use that to represent the uterus in our setting. So when we look at the diagram I'm showing you now, this is pretty much a diagrammatic representation of a HIFU bed. Now you can see we have what we call an MRI table. Now I did mention that the classically was the older or more broadly used technology was MRI guided, but it does have certain disadvantages that I'll touch on a bit later. And the newer versions that we use, that we have in our
Oh, you're muted, Doc.
Apologies, somebody muted me. It said the host muted me, Dr. Bila. So I've just unmuted myself, sorry. So I was saying that the image that you are seeing before you is just a diagrammatic representation of how the HIFU system works. We have the table, and we've got the piezoelectric plate that I just represented now in the previous diagram, or the transducer, which emits the sound waves aiming at a focal point, which is the fibroid, with the patient lying prone on the bed. Now, with our ultrasound system, we don't need the rest of the MRI table, and we do avoid certain disadvantages of MRI, being the fact that, you know, it does cause claustrophobia in certain patients, the loud noise, the issues with metallic objects, and the expenses of it. I will move on to the next slide. Having a little bit of a lag. Okay, so this is a HIFU is cut in terms of the ultrasound guided HIFU that we are using is currently only available in 29 countries in the world. Recently, 2 countries have been added. A year to 2 ago, there were only 27 countries practicing. But what's interesting is that in South Africa, our unit at Chris Hani Baragwanath is the only unit with this technology. In Africa, there is Egypt, and Nigeria has recently acquired, but Egypt had a machine quite a while ago. So if you can see, we are at the front runners of the people who are actually using this technology on our continent. Our specific technology that we're using was developed in 1999 in China by Chongqing Medical University. I've placed the article, newspaper article on the right here from 2015, which is when Chris Hani Baragwanath was lucky enough to acquire a HIFU machine. Now, from what the information I've received, it was kindly donated by the Chinese government in conjunction with our Department of Health, and it was launched at Baragwanath. And since then, it has been largely run by Dr. Setson, who I've mentioned, who recently retired not much longer than a month and a half ago. So our specific model, now just to pause, the HIFU principle of focusing ultrasound waves is possible in multiple ways and with multiple size devices. The device that you guys see before you being a very large, bed that can hold patients of different sizes with a huge desktop system. This is just one of the many different technologies that they have. They do have smaller probes that can be intravaginal probes. They have HIFU probes that can treat do facial treatments. But for our setting, we use this model, which is the JC200, which can house a patient lying on the bed, and we have the control system, which is what you see here on the right. This is a real life picture of our actual unit. So just to show you, this is our control system, which actually has 4 components. Where you see my laser dot, that is our PACS system that actually reports on it. It gives us the MRI images. Now, these are not real-time MRI images that are taken right there. These are loaded images. The patient will have had this MRI 1 to 2 to 3 weeks prior to the treatment. We have our real-time sonar on these screens, on the screens below. On the right screen, that's actually our sonar machine that we can switch between the actual image from the bed, or we have a side probe, which we can use when the patient is not being treated on a stretcher. On the top left of the screen, this is our database where we actually keep all records of treatments, treatment times, energies used. And below that is the actual control screen. That's the actual control interface where all of the commands for the whole system, the whole machine are actually used. What you see on the bottom right corner of the image there, that is a large, it's pretty much our ultrasound and electric center, and it's also our water system regulator. So that's it has a refrigeration system that can cool the water. It also has a heating system that can heat the water, because this treatment requires us to be able to control the water temperatures. I will touch on why we use water as a medium shortly. All right, so just a closer look at the water treatment system. So our water temperature control ranges from about 10 degrees Celsius to 40 degrees. We have a high frequency generator that actually generates the ultrasound. That is that button there. These two represent the water, and there is an emergency shutdown switch in case things were to go wrong. Other than that, the treatment is pretty safe, but the emergency shutdown switch is there just in case we need to completely shut down all treatment in case of a malfunction. All right, so we're looking at components of this actual machine. What you see before you is what we call the combined treatment and visualizing transducer. On top here, we've got a convex visualizing sonar. Underneath it, around there, we've got the treatment sonar and the piezoelectric plate, which transmits sound waves towards a focal point. Now, I'm going to speak a little bit about basic physiology of ultrasound. When we're sending sound waves into tissues, in order for us to visualize, we need those sound waves to pass through the tissues and return to the receiving transducer. That is only achieved by sending those the ultrasound waves at a high frequency of about 3 to 8 megahertz. Now, when we want to treat, we don't want those sound waves traveling all the way through. We prefer them to get trapped and vibrate in the tissues. And so our therapeutic transducer can use high energy, but sends the sound waves at a slower frequency of 0.8 to 2.4 megahertz. So in actual fact, by slowing down those sound waves, we actually get to treat. Okay, I've been through this. This is our 4 monitors. We use it to document the information of the database. We can actually see what we're doing in real time. And we've got the PAC system, which shows us the actual images that we took from the MRI. Now, you might be asking yourself, why do we have to use MRIs and then go and use ultrasound? So the imaging on MRI for tissue is actually the gold standard for imaging tissue. So in order for us to map the fibroids and to adequately know how many fibroids this patient has, what is the size of the fibroids, what is the type of the fibroids, and how vascular are the fibroids, as in how perfused, how much blood is being transmitted into each fibroid. The MRI system is best for that. And so, even though we're using ultrasound guided HIFU, we still need MRI images for us to adequately map and assess a patient for treatment. Then, when we actually treat, we actually look at the patient's pelvis and the uterus using ultrasound. Now, this is beneficial because the ultrasound actually lets us see the fibroid and the wound as we are treating, as opposed to the MRI. With an MRI guided system, you have to capture an image, and there's a lag time of between 10 to 20 seconds before you can actually treat. So you're actually treating blind, even though you had a sneak peek at what was happening. Now, that might be problematic in certain cases, because if patients are breathing deeply, there is a certain amount of movement you can get from bowel. Now, in that 10 to 20 seconds, you can get bowel slipping into the treatment zone, and we do not want such things to occur. It increases the risks of complications. So with the operator console, this is basically our operating system, and it's got 4 sections. This is our piezoelectric transducer control, and it's thought of as a 6-dimensional system. I think of it as an 8-dimensional system because there's degrees of rotation as well. But to take you through it, this control here is to basically move this plate, which is in the reservoir, either to the left or to the right. Now, I'm going to quickly backtrack to just orientate you guys again. If we look at this bed over here, this is the reservoir, which is filled with water. The patient lies across with the patient's head on this side, nearer to where we are sitting as the people operating the system, and the patient lies prone with her abdomen submerged in the water. Now, the reason we use water as a transmission medium is because sound waves actually travel faster through water and are well conducted through water. If you look at submarines and the submarine technology, they use sonar technology and they can communicate for kilometers on kilometers in water. Similarly, whales can do the same. And that is the principle that we are using when we treat like this. So we have to use water. Now, when we use the water, we have to degas the water. So we can't have bubbles in this water system. Otherwise, the bubbles will interfere with the sound waves being transmitted. Okay, I'm going to come back to the control system again. Now, the reservoir is depicted by this diagram here, and this white board is the actual bed. Now, these controls control the transducer and move it left, right, towards the foot, towards the head, so that the focal point can aim towards the fibroid and treat the fibroid and treat it in with millimeters of accuracy. So we have a left, right on here. We have towards the foot, towards the head. We have an anterior, posterior. Now, an anterior would push this transducer down and bring the focal point towards the patient who is lying prone towards the patient's anterior. So if you think of it in layman's terms, it would bring the focal point from inside the body towards the patient's skin. If you look at the PZ plus and minus, this is for the visual transducer, and that moves it also posterior and anterior, but not the treatment transducer. All right. Then we have the rotation. This rotates the actual transducer from a 90 degree to all the way to 180 degree. And that allows us to actually aim and visualize the patient's pelvis and the uterus in two different planes. We can either go all the way from sagittal to a coronal plane when we're doing the patient. This actually says BR plus, BR minus, and this is for bed rotation. So this is where I add the other two dimensions, and that the bed actually can tilt to the left and right and allow us to basically aim at a fibroid depending on what angle we need. The second part here is our actual, it says begin there, that's our actual treatment control. And we've got either a linear system in which we can map out a line for which the machine will actually shoot and emit energy and on a linear pathway, or we can use a dot method where we are simply shooting energy at one specific point and we manually move that point. Begin is what actually allows the machine to actually shoot. And then we've got on the right here, this is our distances for the linear treatment. On the right, we've got our dose parameter control system. And this basically allows us to tell the machine how much energy to give, number one, as in how much power it should be emitting. And you can see that this picture was taken while I was performing a treatment emitting 350 watts. So I was just coming off a test dose, going up towards the maximum, one of the treatment dose of 400 watts, which is what we aim for. When we look at here, we've got a sonication and a rest period. So when I say sonication, I mean treatment, as in to sonicate, as in to give the ultrasound energy. So I'm going to be using that term from now. So when we say we sonicate for 1 second, that's the equivalent of giving the patient 1 second of ultrasound energy at that focal point, and then we rest the patient for 3 seconds. All right, so that is to make sure that that point is heating up. However, there's not a high level of energy transmission to the rest of the uterus, which would be dangerous if we overheated the uterus to the adjacent structures. All right, then we've got here a push in, push out. So this is our control for the balloon. I do have a picture of the balloon later in the slide that I will show you. And basically that will control the balloon getting degassed fluid, which would then allow us to focus the rays either more anteriorly or posterior, depending on, or if the actual machine has reached the limit. All right, now that's the intro to what the HIFU machine actually is and how it works. I want to quickly recap on fibroids, because there's no point in talking about HIFU if you guys actually are not, if we don't know exactly what we're trying to treat. So, and what the problems fibroids actually can present. So fibroids are, number one, the most common tumor that occurs in women, very common in women of reproductive age, and they arise from smooth muscle. Now, when we say muscle, they arise from the muscle of the actual womb. Now, we know that the womb is actually just one big muscle, which is used to put your baby out. So it arises from that smooth muscle tissue. It also has some fibroblast tissue and a high level of collagen. Now that would explain, because collagen is largely found in Black people a lot more than white people, we find a higher rate of fibroids in series in black women versus white women. All right. So if we look here at the fact that HIFU occurs in women of reproductive age, that is one of the biggest problems, in that you'll find a lot of patients that are young women presenting with this problem of HIFU. This problem of fibroids and they want to be treated. But there is a big issue with patients that are very young being treated, number one, with surgical means, and number two, there are controversies regarding other minimally invasive treatments that I will go through shortly. If we look at the different sizes and positions where fibroids can occur, we on the left have a uterus, which, just to orientate you, there's the fallopian tubes, there's the ovaries there, and you can see there's fibroid number 1, fibroid number 2, fibroid number 3 on this uterus, clearly visible, and that could be a 4th fibroid over there. Now, this patient has a couple of fibroids, but if you look at a uterus being on average between being about 8 centimeters, 8 to 10 centimeters, these fibroids are not much bigger than 2 to 3 centimeters each. On the other hand, on this diagram, on this image that you see here, This is an MFU that is gone pretty much out of hand, and we've got these large fibroids that are pretty much the size of a soccer ball. So fibroids can occur in all sorts of sizes and in different positions. And the largest fibroids I have seen, for example, personally, are larger than a basketball, a large overinflated basketball, for example. So it can definitely make the patient look pregnant, even though she isn't. If you look on the right, this is what we call the FIGO system, the FIGO classification system for fibroids. Now, what that seeks to do is it seeks to just create a way of us mapping out where on a uterus the fibroid is. And this allows us to basically recommend different treatments. Now, I know that we're focusing on HIFU in this talk, but for us to appreciate HIFU and its place in the treatment of fibroids, we need to know what the other fibroid treatments are and which fibroids they can treat. If you look at, we've got 8 different types of positions where you can get fibroids. And on here, we've got a diagrammatic representation of the uterus. Those are the ovaries, fallopian tubes, and the uterus. So if you look at a type 1, a type 0 fibroid, that's a fibroid that occurs inside the womb. Then we've got inside the actual cavity of the womb. Then we've got a number 1, which occurs where you have less than 50% inside the muscle of the womb, and the majority is still within the cavity. We've got a type 2, which is slightly more embedded in the actual muscle of the womb, and then we've got a type 3, which is completely in the womb, but it's still communicating with the endometrium. So when I say in the womb, I'm talking about the actual myometrium or the muscle of the womb. If we look at a type 4, that is completely intramural, but just touching what we call the serosa, or the outer part of the uterus. We've got a type 5, 6, 7, and 8. So if you can look at these, type 5 not really connected to the inside part of the womb, and the type 7 is the exact opposite of a type 0, which is sitting all the way on the inside of the abdomen, but outside of the actual uterus. A type 8 is your cervical fibroid. The reason we do this is because not every treatment will be suitable for a fibroid based on the fibroid type. Now, this is just the reason I put this, it's got poor resolution, I won't stay on this slide, is that this is another depiction of what we've just had there, just so that you guys can recognize it if you decide to go and use Dr. Google and have a look if that picture comes up readily. All right, so let's look at the problems that fibroids actually cause. I like to think of it as 5 problems. Number 1, what we call abnormal uterine bleeding, or AUBL. All right, so patients who present saying that their periods are irregular. Either they're having very heavy periods, they're having periods that are coming 2 to 3 times per month, but they generally will complain about abnormal bleeding. All right. Then we've got pelvic pain. All right, okay. Patients who complain classically of what we call dysmenorrhea. They get pain during the periods, but it's not normal pain. This is severe pain. It can be absolutely debilitating, and we have patients sometimes missing work, and it's a serious problem. It can range from mild pain that's chronically constantly there, or it can be severe pain that really makes the patient unable to perform their daily activities. We have pressure symptoms, and this largely occurs when the fibroids get quite big. As the fibroid gets very, very large, it starts to put pressure on the surrounding structures. Now, you can easily guess that urinary symptoms would occur if the fibroids are putting pressure onto the bladder. Constipation occurs on posterior fibroids, or if the fibroid has pushed the whole uterus posterior and it's putting pressure on the intestine, the sigmoid colon going down towards the rectum. Those patients usually will have constipation. There is also the issue of renal issues, in that if you have a fibroid that's putting pressure on the ureter, which is the pipe coming from the kidney down towards the bladder, the ureter, it will basically block the passage of urine and can result in the kidney inflaming, or what we call hydronephrosis. We have pregnancy issues. Pregnancy issues, chiefly patients will come and complain about infertility. Sometimes patients can have miscarriages and poor outcomes in terms of later on they have a preterm labor. We can have patients that have reached near 9 months and they go into labor and a fibroid can obstruct the baby actually coming out. So there are multiple pregnancy issues that fibroids can actually cause. All right. Then the last one is aesthetics. Patient comes in, says, I've got a mass growing, it's making me look pregnant. All right, now I've coded these, AUBL, CPP for chronic pelvic pain, kilopascals, pressure symptoms, pregnancy for all of the pregnancy issues put together. Aesthetics, I've coded that AS, and I want to quickly run through the different treatment options before we now get into how we actually treat with HIFU, and I'll show you a couple of videos. All right, what are the main treatment options? So it's always a good idea as a clinician to approach treatment of a patient with the least aggressive treatment that will have the least side effects on a patient and the least invasive treatment. That will get the job done, however. So that balance is quite difficult to strike sometimes, especially in cases such as fibroids. Always remember to ask yourself, and I'm speaking to my colleagues here, number one, what issue are we trying to treat in order to have the best outcome for the patient? And I'm saying that because we need to look at what is the patient presenting with, because we will not treat all of these issues the same. So we must always ask ourselves, what issue are we trying to treat in order to have the best outcome for the patient? The second thing is we need to ask ourselves, are the patient and the actual treatment options well matched? Which is what we in the HIFU department do every single day when we have a pre-treatment clinic. We ask ourselves, is this patient well suited for HIFU? And I'll be explaining what we think well suited for HIFU actually is. So this is just a hierarchy, and I credit Dr. Setson for giving me this slide. He's actually given me a few slides that I've put in here. HIFU is on, I like that we put it going up to the top of the hill because it is the only treatment that is considered non-invasive. All right. Well, I would argue that certain medical managements are minimally to non-invasive. But this is, in terms of procedures, the only one that is non-invasive. We've got laparoscopy, hysteroscopy, embolization, which we consider minimally invasive, but there is a certain level of invasion in the patient. And then we've got vaginal hysterectomy, which is invasive, but definitely less invasive than a laparotomy. Now, what does non-invasive mean for you guys? This is just a straight example. Now, if you remember, I showed you guys that we are dealing with largely young women of reproductive age. All right. Now, aesthetics is always of concern to young women. And if you've spoken to women, your patients, you'll know that it actually is of concern. We have to balance these things out. It's not just about aesthetics, but it is also about the risk factors of an invasive procedure. The more invasive a procedure is, the higher the severe sequelae for the patient. But I want to give you an example. If you see here the scarring on this patient, this is from an open laparotomy. So if we were to do a myomectomy on a patient and cut her open to take out the fibroids, this is possibly how the patient would heal. The middle picture is a less invasive version of myomectomy, which is our laparoscopic myomectomy, in which we put tiny cameras, camera there, and we put ports that allow us to operate on the patient. All right. With HIFU, this is number one, the first thing that we get in there. There's no skin incision. All right. With HIFU, we're bypassing all of the tissues in between, and we're going straight to the problem. Again, let's look inside. This on the left is a picture of the wound after laparoscopic myomectomy. I've been watching a couple of videos on laparoscopic myomectomy, and I have seen some videos where, truth be told, the uterus is sutured a lot neater than what we're seeing on this image. But you get the concept that a laparoscopic myomectomy does do damage to the actual uterus. Often with a myomectomy, if it's laparoscopic or open, this patient will end up having to have a birth by cesarean section should she fall pregnant, because this confers that this results in damage to the actual uterus, and with damage to the uterus, there's weakening of the uterus, and if she carries a pregnancy, there's a risk of the uterus rupturing and open. With HIFU, got this digital image here where you have nothing, no scarring on the actual uterus, no weakening of the myometrium, and this person can go ahead and have a vaginal delivery should she choose to. All right, a quick run through. I'm going to run through so I don't run out of time because I've got quite a few slides. Okay, I'm going to run through a recap on the possible solutions to the fibroid. So number one, patient comes in, she's got fibroids. We ask what the problems are. What arsenal do we have to treat a patient? We've got medical management, which are pills, injections, got non-hormonal and hormonal. So again, I'm going in order of less invasive to more invasive. We've got analgesics, Panado, the GP's choice, paracetamol. We've got NSAIDs, which is, for example, your Brufen. We've got opioids like your tramadol, and these will chiefly treat the patient who's complaining of pain, dysmenorrhea. Now, the nice thing with your NSAIDs is because they have antiprostaglandin properties, they will also assist with reducing abnormal uterine bleeding. Now, if I was to tell you, this should be your first step in assisting a patient who walks into your room and says, I've got a fibroid. You ask, what is the main problem that it's causing? And you give the patient analgesics, okay? Prothrombotics, we've got tranexamic acid or cyclopentone, which is the main one we use for patients that have heavy bleeding, and this is to stop an acute bleeding. All right. Again, now we've got hormonal treatment, which is now a bit more invasive. I often ask some of my patients, if I was to say I'm going to give you Panado and Brufen, would you choose that? And if I was to say to you, I'm going to give you a hormone, how would you feel? And patients generally will tell you that the word hormone, you're going to give me a hormone, that makes the patient feel a little bit more apprehensive to taking the treatment. So the pill, the combined oral contraceptive, that one is our first line, and it's documented greatly as a first-line treatment for fibroids. It will treat abnormal bleeding. It will also treat your chronic pelvic pain. All right, it regulates the cycle. The problem with this, there have been some controversies regarding estrogen because fibroids do display estrogen and progesterone receptors. And the question was, do estrogen receptors actually upgrade do the combined oral contraceptives upgrade the growth of the fibroid? But the studies have shown that they actually don't. The mainstay which we'll probably use when we're using medical hormones would be progesterone therapy. Okay, we've got oral tablets, we've got injectables, and we've got what we call the levonorgestrel IUS, intrauterine system, or the Mirena, and the implant. But the issue with these is they will not cause shrinkage of the fibroids. And shrinkage of the fibroid is really what we're trying to achieve when we're using HIFU. We've got our GnRH analogs, for example, Zoladex, okay? Then we've got agonists and antagonists, which all work in a similar way, resulting in a gross reduction in estrogen, pushing the patient into a pseudo-menopause or a transient menopause. They don't become menopausal for good, but they become menopausal for some time, and this results in shrinkage. Now, I just want you to see how many of the issues our GnRH analogs can treat. Because it causes shrinkage, it can relieve pressure symptoms over time. But the problem with GnRH analogs is that they are anti-estrogen. They are anti-estrogen, and that results in fibrosis. We have our sperms or our selective progesterone receptor modulators, ulipristal, mifepristone. The problem with these are they're very expensive, not available in government, and they are even difficult to get in private. Okay, but these would result in a similar sort of result. They can cause shrinkage, they will treat abnormal bleeding and your chronic pelvic pain without causing extra damage. Now, our procedures, HIFU. I want you to look at the issues that HIFU can treat. We consider HIFU non-invasive. So the price we're paying for this treatment, the price the patient is paying, isn't a high price. With the potential of treating chronic pelvic pain, abnormal uterine bleeding, reducing the size, which would thereby reduce pressure symptoms and possibly aesthetic, depending on how big it was, with the benefit of not being detrimental for pregnancy. If you put a patient on any of the previously mentioned medical treatments, that patient can't fall pregnant. So HIFU would potentially treat the patient, allowing a patient who is desiring fertility to possibly fall pregnant. If we look at UAE, UAE is also considered minimally invasive. And for those that don't know what UAE is uterine artery embolization. So what we do in this procedure is we insert a catheter and we go to the uterine arteries, which are the two major arteries that supply the uterus. The majority of the blood supply basically block off that blood supply. You might wonder what happens, how can the uterus live on without a blood supply? So it has a small collateral blood supply that comes from up branches of the internal iliacs that will innervate, that will give a blood supply to the uterus, however, in a much lower dosage. And because of that, the lower dosage, the active fibroids, which are innervated by smaller branches, won't get a high amount of blood and therefore begin to die. It is a controversy whether or not UAE can be used in young patients. And I will be straight up and I'll tell you that I don't believe UAE for patients who are trying to fall pregnant is the optimum treatment. We do have some colleagues who swear by UAE. The opinion would probably be by the people who do UAE the most, but there have been controversies. I'll touch on that later, but that is the one issue with uterine fibroid embolization. Besides the fact that we also have to gain entry, so it's minimally invasive, but you have to gain entry around the femoral region, which can result in infections in that region. You can have bleeding, you can have bleeding if you puncture the vessels and they don't coagulate. We've got our surgeries, which is myomectomy and hysterectomy. So myomectomy, again, we've touched on laparoscopic or opening. It can treat all of the issues, all right? It can treat all of the issues. However, the issue with myomectomy is the price we're paying. Major surgery and all of the complications of major surgery and all of the expenses associated with major surgery. Hysterectomy is reserved to patients, obviously, who have just had enough with whatever problem and they feel like they would want to take the womb out. On this note, I know that some of my registrars might be watching or listening in. With hysterectomy, offering a patient a hysterectomy to treat fibroids shouldn't be done as a knee-jerk thing, because hysterectomy itself is not without complications. Hysterectomy also, we do know that we might take out the womb, we might take out the fibroids and there won't be a problem. But we need to think of certain sequelae. For example, we've got about 10% of patients post-hysterectomy in the next 20 years might develop prolapse. So these are the things that we need to consider when we're making our decision for a treatment. All right, so at Baragwana, we basically we send around this protocol and it's available to anybody who might want it. This is how a patient can be referred for HIFU, but our basic criteria is we generally cap it at around 45 years of age to be eligible. The uterine size, as in the size of the actual uterus, should be around about the belly button or below, around about 18 weeks, okay, 18 to 20 weeks. We do sometimes consider it case by case, depending on the patient's specific situation. We obviously have to have a confirmation of fibroids. And we accept a registrar sonar or a higher level. We don't need formal sonars. And in any case, as I always tell the registrars, your sonars should be the paramount sonars. You should be able should be confident enough in your sonars to actually send them for HIFU. Recent valid pap smears, so that we're not trying to treat a patient who has a pre-malignant cervical lesion. And then for those patients who have abnormal bleeding, we would like endometrial sampling of some sort, a Z sample or a hysteroscopy with biopsy if that's possible. We put the number for the department on this PDF that's stuck around the hospital and circulated to our colleagues, and then they can basically refer the patient through to Baragwana. We run 2 clinics, a pre-treatment clinic and a post-treatment clinic, and in between we do treatments on Mondays to Thursday, Monday, Wednesday, and Thursday. All right, so which patients are appropriate for treatment? All right, so now that we know the background to the treatments, we're going to get a patient, which ones are appropriate. Number 1, patients that aren't obese. The reason obesity is a problem is because the abdominal wall is quite thick, and trying to send the sound waves through the abdominal wall results in, number 1, a higher risk of burning. Number 2, if we have a 6 centimeter thickness of fiber of the abdominal wall, it increases the distance that the piezoelectric plate can send the actual beam to the focal point. And therefore, if the fibroid is posterior or further away from the actual plate, our actual transducer, we can't reach it. So obesity is an issue with some patients. We have had some patients that have come who have got the issue, they're obese, and they have not been able to or cannot get any of the other treatments, and we've sent those patients on weight loss programs. Uterine size, so we've advised them to lose weight, and hopefully if they do come back, we might be able to assist them. The uterine size, okay, as I've said, 18 to 20 weeks. The patient we have to be able to see the fibroid on ultrasound. Now, this is one of the points that slightly, I wish we could maybe upgrade our system. So our system was donated in 2015. So the resolution on the ultrasound component isn't as nice as the ultrasound that we have today. Some of our ultrasounds can have it. I'm sure we'll be able to treat a lot more fibroids. But again, you can't treat what you can't see. So generally, we find that if the fibroid is above 2 centimeters, it'll be visible on ultrasound and we can treat it. Patient must have a normal pap smear. I've touched on that. No intrauterine devices. So if the patient has a Mirena or a copper T, we have to remove those devices. And the patient should not be pregnant or lactating. All right, so patient needs to also be in good health. We don't want the patient to have a lot of abdominal scars. For example, if the patient has had multiple vertical incisions on the wound, the risk of burning is high. And that's because those sound waves will catch in the scar tissue. They're moving at a slow frequency, and it will increase the heat in that focal point, and the patient can burn on the skin. The patient has to be able to lie prone, as I've shown you guys, for 2 hours without moving. And the patient has to be able to communicate with us, the treating doctors. We obviously request the patient to have a routine gynecological exam to exclude pregnancy, infections, adnexal masses. I'll put an asterisk there because certain cysts might become pap smears, cervical dysplasia, and pre-malignant lesions. We will not treat those patients. Okay, so I've actually got that. All right, so let's talk about the MRI now. There's a classification system. Now what I'm going into is which fibroids can we actually treat. So there is a classification system called the Funaki classification, and I stand to be corrected, but I think this was by a radiology professor based in Chicago, this system, I think Brian Funaki, and he developed a system that basically looks at how the fibroids or how tissue will look on an MRI when we're looking at proton spinning that will spin differently in fluid, in blood versus other tissues. So what we end up getting is we get hypo-intense, which means it is darker on the MRI, and hypo-intense would also mean there is less blood, so it is less vascular. So the less vascular fibroids, these ones are good and easier to treat. So if you can imagine, because we have blood moving through the fibroid, if we don't have a lot of blood moving through the fibroid, the heat that hits the fibroid doesn't dissipate. If we have a highly vascular fibroid, when the heat or the ultrasound waves hit there, all of those the heat will be dissipated by the blood that's actually moving. So it makes sense that a highly vascular fibroid would appear hyperintense and wouldn't be a good candidate for HIFU. Other things that make a fibroid unsuitable would be if it was pedunculated, I've mentioned, sticking out into the uterus, okay? But if the stalk is thick, we would treat that. We wouldn't treat a pedunculated fibroid with a thin stalk for the sake of, we do that, we might actually release a loose body into the abdomen. And that's why that one would probably benefit from a laparoscope. Fibroids in the uterine cavity, again, we wouldn't want to treat those because ablating the innermost part of the uterine cavity would burn the endometrium. And if this patient is desiring fertility, we're technically doing an endometrial ablation. So fibroids in the uterine cavity, we would prefer to treat by hysteroscopy. So here's just an example of a Funaki type 1, a Funaki type 2, and a Funaki type 3. So as I was saying, I said it was in terms, as much as it reports on the vascularity of the actual fibroid, I'm just going to orientate those that might not know what's going on here. This is an image of a person standing facing the left, and this is the anterior, and this is the patient's buttocks. And this here is the wound. And when we look at the patient's wound, this thing that we see here is the fibroid, all right? And this is the patient's spine, and there we've got the coccyx. So here is our fibroid, and you can see that the fibroid is darker than the myometrial tissue, and this makes this a Funaki type 1. This one here, you can see the fibroid. Similarly, you can see the uterus, and this fibroid here is of similar appearance to the actual myometrium, and this makes it a Funaki type 2. On this image C, we've got the fibroid, which is looking quite white on this MRI, and that is hyperintense. It is more intense than the myometrium, and this is a Funaki type 3. This fibroid is also probably highly vascular. All right, so now our process. I've discussed the mapping. So the first thing we do is we map using what we call the T2 MRI image. So T2, as I've said, it's the type of MRI that we want. And we get two images. We get a sagittal and an axial plane. So for the guys who want to refer to our unit, please, if you are going to do the MRI for us before referring, all we need is sagittal T2, and we need an axial T2. We don't need any other image modalities from the MRI. To give you an example again here, we've got, this is actually a treatment that we did 1 or 2 days ago. We've got a simple cyst here, quite a large one. And then we've got the fibroid here. The patient was highly symptomatic. And this is the transverse. Now, if you get, this is the axial view, and you can see in here that there is a degenerative appearance within the actual fibroid. This here is another treatment we did in the past few days, and this patient has 2 fibroids. So to orientate you, this patient is lying prone. How we do when we treat the patient. Here's the spine of the patient. There is the bladder, so fluid appears white. Okay. Here we've got the ovary with 1 or 2 cysts. Okay, you can see there the follicles on the ovary, and then here we've got our womb. We've got the endometrium here. So we don't want in young patients. This is a 38-year-old female, as you can see. We want to conserve the endometrium. So in approaching the treatment for this patient, this fibroid can be readily treated from the center there. But when we treat this patient, we would have a curtain of security here where we do not treat. So we would have about 1.5 centimeters at least where we would not treat this fibroid. We would treat it from about this level below. So we would treat the fibroid, all of this, and try to get this to this is just the axial view of the same thing. So you can see that with this patient, the endometrium is lying on the patient's skirt. Okay, I see we've hit 7 o'clock. I'm going to run through the rest of the slides. There's not too many left. Pre-treatment, about 3 weeks before. Then 2 days before, we do a bowel prep, which means we empty the bowel. The patient basically takes laxatives for 2 days. In terms of bladder training, the patient has to learn how to hold their urine. So we generally tell the patient to 3 weeks before, when you feel like peeing, look at your watch, hold it for 30 minutes. A week before, try to hold it for 1 hour. 2 weeks before, and the week before, try to hold it for 2 hours, because the treatments generally average 2 to 3 hours, depending on the fibroid size. On the treatment day, we will do a skin prep of the patient's abdomen. So we want the abdomen shaved, number 1. We want it degassed. Remember that sound waves do not like air. So we want the skin degassed as possible. And what you see that looks like a shower cap, a shower head on the right here, this is actually a suction device for degassing the skin. And then we don't want the patient to put oil on. So if the patient has put on body lotion or oil, we'll just remove that with alcohol. And then we catheterize the patient in order to fill the bladder. All right, in terms of the anesthesia, we do this process under conscious sedation. Now, this is one of the benefits as well. A patient that undergoes conscious sedation doesn't undergo as much risk as a patient that is given a complete GA, for example. So one of the benefits is that HIFU can be done under conscious sedation while the patient is awake. We actually want the patient awake. And there's an anesthetist who monitors the patient. In China, the actual conscious sedation is done by a trained nurse, but obviously in our setting, we haven't gotten to the level where we can hand over such a responsibility, but maybe in the future. If you look at bladder filling, the reason we fill the bladder is because we want to ensure that the medium is fluid. So we fill the bladder artificially with saline, but it's degassed saline, so we make sure there are no bubbles in it as well. The patient must be conscious so that they can report womb pain, back pain, leg pain, and if their skin gets hot or is burning. That is the real reason we want the patient conscious and not asleep. Now remember, we're dealing with heat and we're burning the fibroids. If this heat spreads and dissipates towards the back, the patient will complain of back pain. All right. It's also a normal thing for the patient to complain of back pain if we are, because the womb, the nerves from the womb are innervated and innervated by sorry, they're innervated by the nerves that go up into the lower back. And so patients that go into labor, patients that have severe wound pain will commonly complain of back pain. We do get lower back pain complaints while we're treating the patient, especially when we begin ablating the fibroid. As the treatment goes, they complain. Usually they complain less. But if the fibroid is in close proximity, we must be conscious of that because you can damage the vertebrae and the nerves in the back. Wound pain is pretty much normal. That's why it's got a double asterisk. We expect that because we're causing ischemia to the fibroid. And with ischemia, the nerves die, the tissue, the cells die, and the patient will have wound pain. And that is the chief reason why we have an anesthetist giving the patient strong analgesia and slightly sedating the patient. Leg pain is a no-no. We do not like leg pain, and leg pain is basically dangerous because that would let us know that the heat is reaching either the left or the right nerve plexus, which is dangerous. If you damage those nerves, you can give the patient long-term sciatica. You can give the patient foot drop. And then if the skin is hot, we obviously know that you can give the patient first or second degree burns. Now, with all of these major risk factors being noted that we can damage structures, you also need to bear in mind that we have to be very, very careful not to damage the bowel. And the bowel must be way away from the treatment area, which is why we do a 2-day bowel prep prior to treatment. Okay, I've got a little video that I'm going to show you guys here. This is called the power test. It's how we basically just check that the machine is working properly. So we set it at 100 watts. We put a protection cap on the machine, and what we want, and we set the focal point at the level at which the level of the water. So we want the actual sound waves to hit at the surface of the water, and if there is enough power being generated, we will get a fountain effect. I hope that we will be able to play it. I'm just going to try and play it. Okay. Two, one. Okay, and so you'll see that these sound waves are so strong that they can cause a fountain of water. Now you can imagine the patient is lying on there. We technically can, there are videos where, and I wasn't able to source one of those videos, but we can technically even write a pattern in the patient, a pattern using the heat at a specific focal point in the tissue that we are treating. Okay. We then do what we call the flower pattern test, and here what we're doing is we've got what you're seeing here is the piezoelectric plate. We are shooting the sound waves, and we want it to converge at a focal point right here. And what we have here is a diagrammatic representation that we want the focal point to be the place where each area that is shooting that is converging the sound waves is sending the sound waves in a straight direction to meet at one point. If that happens, you get this image that you just saw there. So you get that pattern, which is a floral pattern, and that is what we call the focal test, the flower test. This is a treatment, a live treatment. I am speaking during the treatment, but I'm just going to quickly orientate you guys. So what you see here is the control interface, and this is a patient with a fibroid with a calcified border. It's quite light. It does look better a bit, but the resolution is a little bit better in real time. The bladder is here, and what you see here is actually the bowel, which is way out of our treatment zone. So this here is our treatment zone, and this we haven't started the treatment yet. So this patient is untreated. We've got here a little bit of a calcification of the border of the fibroid. And to just show you what it looks like when we actually start to treat, I want you to look in this area. I hope it's not too light so that you can actually appreciate what we call the grayscale change which we look for. But in real time as we treat, you can follow my arrow that I'm speaking there. You get what we call grayscale change, and you can literally see the fibroid beginning to coagulate. And what happens is it becomes white. It goes from being dark to being lighter to being gray to being white. And that's what we call grayscale change. So if you can look here, there's grayscale change on the right, and this is with a 200 watt test dose. So I'm using a very, very low test dose, and we're already getting grayscale change. And this was a Funaki type 1 fibroid. Okay, this here is an example of, if you look on the left, we have a fibroid that I've just mapped out where these are the treatment points. So we were still adjusting. And once we started to treat, we immediately began to get quite good grayscale change on the inner part of the fibroid. Now, to completely treat a fibroid, all we need is to treat about 60% of that fibroid volume. We call it the non-perfused volume. And if you treat about 60% of it, that fibroid should regress. So here's just an image of grayscale change, because I wasn't sure that you could appreciate it on that video. So then what happens after that? We basically then follow up the patient. And here's an example of a patient before HIFU. You can see that there's a Funaki type 2. And 2 weeks post HIFU, you're already getting, it's now becoming less vascular, so it's appearing darker. And then we have 4.5 months, and 10 months later, we're getting size regression of this fibroid. Okay, now part 3. I'm just going to quickly tell you guys about what, in actual fact, how our outcomes have been. So with that, you just have to also think of our advantages. So we do HIFU as a day procedure. Patients don't get admitted, they don't stay over in hospital. They come in the morning, get treated, get recovered, and they go home. That avoids the whole issue of hospital bed stay, risks of COVID, and it is non-invasive. It spares the uterus. We've been through most of these, I've mentioned most of these issues, but the patient recovers very quickly and returns to work within a few days. What are the possible complications? Number 1, we can get transient complications, pain, which is from the ischemia I've mentioned. You can get it in the back, in the legs, skin toxicity. Skin toxicity, we can get burns. We can get bowel injury, bladder injury, endometrial damage, Asherman syndrome, and nerve injury. Now, I know I've listed a whole lot of complications, but these are theoretical complications that can occur. And if you do conduct HIFU properly and you're diligent and careful with the manner in which you do it, the complication rate is very, very low. Another thing is HIFU doesn't have any ionizing radiation, okay? We can repeat HIFU treatment. So if a patient hasn't had an adequate response, we can repeat the treatment with the same risks. And there is no damage to the ovaries. So there have been questions when we do send that heat, does the heat get to the ovaries and damage the ovaries? And we've done tests, there's been research that has looked at what we call the anti-Müllerian hormone, which is a biomarker for ovarian reserve. And there is no drop in anti-Müllerian hormone with post-HIFU treatment. It's cost effective. Now, we might discuss the cost later, but it is cost effective when you look at the overall costs with hospitalization. We have a decreased stay, the equipment needed to perform the procedure versus other HIFU treatments, and we don't need to transfuse the patient because there's no risk of bleeding during the procedure. There's no HIV transmission because we're not cutting into the patient, between the patient and surgeons. The risk is low, and all in all, it's safe with a low risk. So I'll put a caveat down here that what I'm about, these statistics that I'm showing you here are from our last audit, which was pre-COVID. So we haven't been able to conduct a proper audit of our department statistics during the COVID pandemic. But pre-COVID, we had treated 410 patients and in this series, and now we're at 500, approaching 600 treatments. The average age was 31 years of age, which we can expect because its patients are of reproductive age. The average weight was 79. We do taper that because we obviously exclude obese patients. But the abdominal wall thickness was on average 4.9 millimeters. The main issues that these patients presented with was number 1, abdominal pain, which was your dysmenorrhea or severe period pain. They this was after the treatment. A lot of them during and after the treatment. Sciatica or buttock, we consider these two quite normal. The burning sensation of the skin, just under a third of our patients get that, and just over 10% of patients who complain of transient leg pain. Now, our main issues that the patients were presenting with was period pain, abnormal bleeding, which can result in anemia of the patient. Some were complaining about pregnancy issues, not being able to fall pregnant. Constipation and urinary frequency was about 37 to 30 and 35% respectively. This diagram here is what we call a symptom severity score. Now, this is post-treatment. So we follow up the patients and we do an assessment where we ask them the severity of their symptoms before HIFU. And you can see here that this score has a scale of 60 as the most severe. So it's an arbitrary score that uses 60 as the most severe and 0 as no symptoms. Pre-HIFU, patients had severe symptoms. 1 month later, it's dropping. 3 months, by month 3, there's an improvement in symptoms. And when we say symptoms, we're talking about all the chief symptoms I was talking about, from bleeding to pain to constipation. 6 months, we've got more than a 50% drop in symptom severity. And by 24 months, patients are complaining of mild symptoms, with some patients having complete resolution of their symptoms. So in terms of shrinkage and size, remember that HIFU treats, it actually causes shrinkage of the fibroids. We have an average of 31% size shrinkage, and what happens, how we get this data is we measure the fibroids at month 1, month 3, month 6, and 1 year after treatment. And we take a percentage of decrease. So here it's all just been lumped up, to be honest. It's a crude analysis of what the percentage shrinkage is. But at 1 month, 31%, 3 months, 52% of patients have good shrinkage, and then 6 months at 61%. And then at 12 months, we have 73% shrinkage. And that's the size, sorry, not the patients, but the size relative to the original size of the fibroid. All right, so when we talk about our major adverse events, what have we had in our department? Remember all of the issues that I listed, of all of those we've had, of all of the 570 cases we've currently treated, we've had 2 cases of first degree burns, and these were actually a few years ago, not recent. First degree burns, by that we mean blistering, and this resolved spontaneously in the patient. There's been 0 bowel injuries. There's been 0 bladder injuries reported. The nerve injuries, there have been 2 cases, all right, which both had spontaneous resolution. We do have a case from last year where a patient was complaining of slight nerve in the left leg, but it was preceding the actual HIFU treatment. We've got rhabdomyolysis, 1 case of rhabdomyolysis. We then found out that this patient actually had underlying rapidly progressive glomerulonephritis. There was 1 case of a severe non-resolving anemia in a patient, but interestingly, this patient had actually the abnormal uterine bleeding had resolved post the HIFU, and she continued to have a severe anemia. Then that prompted us to do a medical workup of the patient, and we found that she actually had an undiagnosed lymphoma, sadly. Okay, so this brings me towards the end of my talk. General issues that people will want to discuss is, number 1, should HIFU be done? And I'm just going to jump straight into it, because these are the things in our department, we get sonographers rotating through, and these are the things we generally discuss. I mean, the first one is HIFU a gynecologist's or an interventional radiologist's treatment? Controversial. But I would easily say that I think us as gynecologists are well placed to actually conduct HIFU, and this being because of the fact that, number 1, we basically sonar the pelvis every single day, and we do multiple sonars every single day of our lives. That's my first argument for that. And then number 2, I believe that our approach to treating a patient with fibroids shouldn't be based on 1 single intervention. We have patients that come for HIFU, we put them on, and we do the MRI, And when we're about to treat, we decide, you know what, let's treat the singular fibroid. We will send the second fibroid for a myomectomy. And if that is done by a gynecologist, the continuity of care is maintained. So with regards to MRI and ultrasound follow-up, so there's been a couple of questions asked that should we be following patients up, as I showed, with serial MRIs. And in our department, we don't, because we did initially when the HIFU first arrived. But because of the fact that an MRI is actually a resource, and in our setting, it's a really valuable resource, so we follow up our patients with ultrasounds. So we measure the patient's fibroids with ultrasounds afterwards. And I think that if we could have good quality ultrasound machines, ultrasound follow-up is more than adequate. There's an issue of adjuvant therapy. So this is one of the research things that we are currently about to conduct in our department, where number one, we know that HIFU can shrink fibroids, and we are having a good reduction rate. What happens if we add neoadjuvant or adjuvant treatment, which is add Depo-Provera to the patient while we're giving, in 3 months, while we're giving post-treatment? What if we add Zoladex to the patient after treatment, for the 3 months after treatment? So that's one of the things, the areas that we're going to be looking at. And then there's the issue of HIFU in the private sector. I think it's inevitable that it will be coming to the private sector at some point in time. I think that, you know, a public-private partnership should probably be looked into, in that a lot of, I mean, we now treat private patients. We treat patients that travel from Cape Town. We treat patients from George. We treated patients from all over South Africa, really, because we are the only center, and we do not discriminate against patients. All patients are equal, and we treat patients from private or public, you know, equally. They follow the same process, the same booking process, and once the patient's in the system, we do offer that. But we definitely will need more machines in the future for our country, really. And then there's the common question of the leiomyosarcoma or fibroid. How do we know that we're not actually just treating a leiomyosarcoma? Well, firstly, I have bothered the MRI professors with this, the radiology profs. I often go there and I say, tell me, what are the features of a leiomyosarcoma? We've read on it as well. It's not easy to, on an MRI, differentiate between certain types of fibroids, like the Funaki 3s versus an LMS. It's not easy. However, we do know that HIFU treats cancers. So on the off chance that it was actually a leiomyosarcoma, the fibroid would probably be ablated, and would probably have more benefit than the possible risk of spreading the leiomyosarcoma. Our current research plans in the department, I've mentioned. Number one, we've got a protocol going for adenomyosis treatment outcomes. We are looking at pregnancy outcomes. So just regarding pregnancy outcomes, we have had over the past 11 or so, during the COVID period, we've had patients coming in spontaneously with pregnancies, and these are patients that have had 2-3 years of attempting to fall pregnant, and the only issue that was identified was the fibroid. Now, obviously, this isn't robust in terms of evidence. We would have to structure the study properly, which is what we're trying to do. We will have a retrospective analysis of those patients, and we are also planning a prospective trial with one of our infertility subspecialists, Dr. Mukudwane, where we're going to be looking at baseline anti-malaria hormone levels, making sure the tubes are patent, and then we'll be looking at the differences pre and post HIFU treatment in pregnancy rates. Then we'll also be looking at using adjuvant therapies and shrinkage rates that come from the different adjuvant therapies, mainly Zoladex in our case, and we'll be hopefully trying to report on that in the next year or so. Which brings me to my conclusion. I'm so sorry, I've probably gone way over time, but like I said, this topic, I mean, it's a topic that hasn't really been discussed a lot, and I couldn't omit some of the information I was talking about. But in conclusion, basically, I think that if you look at from treating a fibroid perspective in our context, HIFU has a huge place in the future. I think it's an understatement to say it has a place. I think it has a huge place in that it might pretty much become first-line therapy in the future, and it shouldn't be seen by our as a replacement to our current treatments, though, because our current treatments have their place depending on what the patient actually has and what symptoms the patient has and the type of fibroids in the patient's situation. Every treatment that I've mentioned tonight has its place in treating fibroids, but HIFU should be seen more as an addition to the arsenal that we have. So all in all and in short, I think HIFU is very much part of the future of treating fibroids. And I thank you for the opportunity to have addressed you tonight. And that's just our department. We're a small unit. On the left, you see our Dr. Setson, who has left us. And then you see Dr. Williams, Sister Naomi, Sister Sylvie, and Sister Joyce. And that was myself and Dr. Setson, who I'm eternally grateful to, who I consider a good friend and a mentor. And I hope he was watching. Thank you very much.
Thank you very much, Dr. Mpehle. It's been an exciting, a wonderful presentation. As you say, we've given you enough time because it's something new that we have not discussed. Something new that is in the marketplace in terms of the arsenal that we have for treating fibroid disease. And when you continue speaking, I could say that you were actually answering most of the questions that are on the chat line. So I think there won't be too many questions to discuss after this full presentation. I've got two questions from my side. Well, I think you've answered the one about the availability of HIFU in the private sector, because I think there were lots of questions, people in Cape Town asking, can we have this? What about in the private sector in Johannesburg? And clearly it is that we can only have, the only place where HIFU treatment is available is at Chris Hani Baragwanath Hospital at the moment. And you are the leading light in this particular modality of treatment. And thanks to Dr. Sanson that you mentioned. I think I happened to work with him many years ago when I was in management and I was at Chris Hani Baragwanath. We thank him for that. Second question that perhaps also going forward, we could consider, you said this is not, it adds on to the arsenal, but bring radiologists, interventionists to discuss about the role of obstetricians, gynecologists versus interventionists in terms of treatment of fibroids, which brings me to, you mentioned it, uterine artery embolization. What is that you have against it? And is that a place for gynecologists currently, or is it only a domain of radiologists? I've had a discussion in the past. I won't tell you what I said to the radiologist about what I thought they should be doing or not be doing in terms of treating fibroids. I just want to hear from you.
No, thank you very much for that question, Dr. Bila. In fact, I had this question even when I was a registrar. In fact, I had traveled to Cape Town and I was discussing with a couple of the consultants there at the time, in that I always wondered why uterine artery embolization was not conducted by gynecologists at the time, and why we weren't trained to do it. I've received all sorts of, and I'm going to be blank here, and I'll just say it as it is. I've received many opinions. Number one, I've heard people say that as a treatment, it was stolen from gynecologists, which is preposterous. Obviously, I don't think that we should be looking at anything like that. It is a funny notion, nonetheless. I've also heard that because we do not actually deal with internal catheterization of vasculature, the person who is more fitting to do a uterine artery embolization is in fact the interventional radiologist. And I do believe that it is their place to actually do such a procedure. My issue arises when we have a separation of functionality between departments, in that this is clearly a state where there is overlapping. Now, the nice thing at Baragwanath is that we have a gynecologist who actually works with our interventionist in performing UAE, which is what I believe should be the case in almost every UAE department or fibroid treating department, being in that our focus is patient care, and the patient should be central, not the procedure or not the actual institute, or not the doctor. The patient should be the center or the focus. Now, when we put the patients at the center of the focus, it becomes easier to answer the question, who should be the person overseeing a certain treatment? Now, when it comes to HIFU itself, HIFU should be done, I believe, by the gynecologist because of how technical, number one, it is to understand the differences between the different fibroids, the differences between the patient's actual presentation. In terms of the actual procedure, it can be done. Obviously, an interventionist would be overly qualified to just sit and do the HIFU, but would technically be turning them from a doctor to just a technician. Whereas with every treatment, you want to be treating a patient as a doctor. Every single clue when you're treating a patient is actually integral. The research that has come out on UAE has largely looked at UAE in terms of what UAE results are like with fertility. Now, I did go on Cochrane, and I can't say the jury is completely out, but it is definitely leaning towards saying, and I've spoken to a lot of our infertility colleagues, towards saying, if a patient wants to conceive, uterine artery embolization is not the best treatment for that patient, because it reduces the blood supply to the uterus. I mean, it stands within good logic that if an organ is to function optimally, it needs a good blood supply. Now, if we're to diminish the blood supply of the uterus by over 50%, what are the chances that that uterus is going to conceive? Is going to conceive and conceive at a rate that is not decreased. And so the Cochrane review shows different studies. Some studies have shown a huge drop in reproductive outcomes in patients post UAE. Other studies are equivocal. In terms of the myomectomy, we know that myomectomies have good outcomes post myomectomy, but it does carry a high morbidity for the patient. You know, so in all, I say again that we shouldn't be looking at it as HIFU is going to replace UAE. It definitely will not. We've had patients that present that are maybe 40, 45, 46 years of age, are approaching 50. So those patients are unlikely to want pregnancy. When they are of that age, we look at the fibroid type. We still will consider them. I did see a question saying why 45. So 45 mainly because above 50, when we get to 50, the incidence of cancerous masses does increase. We don't expect postmenopausal patients to be having issues with tumors within the womb. We'd expect because the estrogen goes away, those patients don't have that. However, we do look at individualized cases. We wouldn't completely send the patient away if you thought you could motivate for the patient and she's above 45. But in that same notion, what I'm saying is, if you have a patient above 45 who's not going to be looking to fall pregnant, that patient can definitely benefit from a UAE if we can't do other treatments. We've referred many patients for UAE that we thought it was not the best way, HIFU was not the best treatment for them.
Okay, thank you very much. We may have time for only 2 questions, perhaps, because we've overrun our time. After how long post-HIFU can one attempt to do myomectomy on a patient that has failed a myoma shrinkage from HIFU? Does it change the plane of the fibroids?
Okay, yeah, thank you very much. So again, that is one of I didn't mention that on our research point, but we will be looking into that. So generally, after HIFU, we will want to follow the patient up. As you saw on my previous slide, we start to see shrinkage from as early as 3 months. So we will observe that patient for shrinkage, for Doppler activity, and to see if there's still, a blood supply to that fibroid. If we see that it's not shrinking, the patient is still symptomatic, we have an option to repeat a treatment. If we don't want to repeat a treatment, or the patient elects to say she now wants to go for a myomectomy, there is there's no recommended waiting period to go ahead and do a myomectomy. It has been reported that after myomectomy, there is in some patients a loss of planes, a loss of the surgical plane, which can make the myomectomy slightly more difficult. Which also has been reported with patients who, for example, receive Zoladex. Zoladex, in that because it starts to cause a shrinkage of the fibroid, obviously the fibroid is degenerating, so that plane, that hard shell that makes it easy to surgically remove the fibroid starts to disintegrate or to blur. And so we do think that HIFU would probably make the actual surgical excision of the fibroid a little bit more challenging, but we are not at the stage where we know for sure. We are currently developing a protocol to answer that question there.
Okay, thank you very much. Yeah. Somebody wants to know, moving away from obstetrics and gynecology, if there's no bleeding, why not use it for prostate enlargement and tumors in the blood and the bones and GIT? Okay,
so thank you. That was I explained in my second slide to whoever asked that question that HIFU is, if you look at the scope, it's actually used overseas for prostate, it's used for liver, it's used for pancreatic tumors, it's used for bone tumors, which then obviously I'm sure we're all thinking, why are we only using it for fibroids? And it's inevitable that this technology needs to expand. And if we are honest with ourselves and we look at the greater good and all of the patients, we definitely need to expand this and be able to treat prostate. So our general surgery colleagues need to come on board. We need to have our urology colleagues coming on board so that we can expand and offer this treatment to other patients. But it definitely can be used for those other modalities. And then, sorry, Dr. Gill, I just want to answer two questions here. Number one, there's a question about have there been uterine ruptures reported after HIFU? They haven't. Well, in the large series that I read, there was definitely not an increased rate of uterine rupture. And there were confounding factors in the case of uterine rupture that I did read, but it's widely recognized that HIFU does not increase the risk of uterine rupture. It does not. And then the second question I'm reading here on the screen is about formal consent for HIFU. Is there a delay in fertility? Is there formal consent and is there a delay in fertility post-treatment? Okay, so first of all, regarding formal consent, there's formal consent for everything, absolutely everything, especially HIFU. We speak to our patients and we don't do HIFU without rediscussing all of the other options that the patient has. We always make sure that the patient is fully informed, knows what the procedure is. And yes, just like with anything in medicine, there has to be formal consent and it must be fully informed consent. Regarding the delay in fertility post-treatment, we do recommend from our international colleagues, it's recommended that post-HIFU, because there's an inflammatory reaction in that degeneration and the resorption of the fibroid, we recommend around about six months of abstinence from conception. So we generally do tell the patients, which is very important. If you have a patient who comes in and says, and she's 39 years of age, and she wants fibroid treatment for infertility, that patient with me, we literally discussed with the patient and explained that, look, we have to weigh that up versus the other treatments, because with this, we will recommend you delay falling pregnant for 6 months. We don't know what your ovarian reserve is. So that is why, from an infertility perspective, that delay is very integral and the patient's age becomes a big factor. Someone's asked the maximum times to repeat HIFU. Theoretically, there's no real maximum. However, we generally won't repeat more than twice. In our department, if we repeat it twice and we're not getting a desired effect, we can send the patient for an alternative treatment. But this is provided it's the patient's index presentation, and with this presentation, the patient is still having symptoms. If you have a patient who was treated 3-4 years ago, comes back, it might be a new fibroid that's formed, we can treat that fibroid. Go away, you come back 3-4 years later, we can treat that fibroid. So from a technical point of view, there's no maximum times of repeating HIFU, as opposed to, if, for example, myomectomy, you do your first surgery, it's okay. Second surgery, it's still okay. Third surgery, it starts to get a little bit difficult. And the more surgeries a patient gets, all of us surgeons know that it becomes highly risky for the patient and complication rates.
Okay. No, thank you very much. I saw there's a question about maybe, I'm sure it's some of your registrars, they want to have access to the presentation and also perhaps the recording. Just a response, we do record these presentations. I hope you saw that with your permission. It will be available on YouTube, so they can have access to that. I hope that everyone who logged in today, you gave us your details so that you can submit your CPD point, apply for CPD points at the HPCSA on your behalf. And that we can also send you a survey after this presentation, which will come tomorrow morning. And also that then you can get a link, our YouTube link, so that at least you can have access to the whole presentation and the talk. Are you quite okay with sharing this presentation with us so that you can give it back to whoever was connected to this evening, Dr. Mpehle?
Oh, no, I'm a man of the people. I'll share the presentation, no problem.
You share it with us. Yeah, you can share it with us also. Okay.
No problem.
Yeah, I think we've run out of time. We can speak. I think you can talk to us more than 2 hours. I can see that.
I really can on this topic. So thank you very much again, Dr. Bila. Thank you to the clinic's management. Again, thank you to Dr. Sitson. Thank you, Dr. Williams. Thank you to Professor Adam for the opportunity. And thanks for everybody, to everyone for listening. Thank you very much.
Now, we want to thank you very much for accepting this invitation to come and share your thoughts and what you're doing. Great work that you're doing there at Referral. We're thankful to you, and also to Prof. Adam, who introduced you to us, and we are grateful to her. As you mentioned, some number of colleagues are saying that they want to thank you for mentioning Dr. Sesson for the good work that you have done at Referral. And so on behalf of clinics, I just want to thank you for being with us this evening. And we hope that when we call you again next time, you won't say no. And we just want to thank all the colleagues who've joined us this evening. They stayed on until the end of the presentation, which shows that there's a lot of interest in this topic, and we're quite grateful to you and to all of you who've been joining us at clinics all these times that we've been doing this weekly webinars. I also want to thank the marketing team from Clinics Health Group. Tonight we've got Zoki, who's behind the scenes, making sure that we have these presentations and making sure that they send invitations to all of you. Thank you, Zoki. I just want to say thank you very much and have a good evening. Thank you.